Welcome everybody to our first plenary of the morning, and Dawn and I wanted to share with you some thoughts that we've had about changing our mind, learning. It's a kind of a way to think with humility about how we constantly learn. But we thought we would begin by just this morning recognizing Fee's wonderful session on to commemorate Tom Nolan yesterday. Tom meant the world to us. Tom is the person who brought quality improvement science to healthcare, and he really is the person who taught us to change our mind. I remember very early on meeting with Tom, and we would be trying to tell him about the complexities of healthcare and how difficult the work was, and Tom would sit there and listen to us, and then very quietly he'd often say, "That's one way to think about it." And he'd pause and reflect. And the way that he taught us was to constantly be thinking about how to change our mind.
Yeah, Maureen and I have realized, although we didn't start there, that in a way this session we view as sort of homage to Tom. Perhaps most of you in the audience didn't have the privilege of getting to know him, but you've all been affected by him. Tom was the originator with John Whittington of the Triple Aim. He was the person that brought the Pursuing Perfection project, a very generative project, to IHI. He's the author of the framework Will, Ideas, and Execution, which we've used over and over and over again as a guideline for our education of leaders in healthcare. He also, with his colleagues at Associates in Process Improvement, is the author of the Model for Improvement, which became the mainstay technical model for IHI. He's given us more than perhaps any other scholar in the entire history of the organization, and personally, by far the best mentor I've ever had. I remember my first meeting with Tom, the first time I ever met him in person, he came to what was then a very young IHI, and I heard about him and asked him to help, and I remember him sitting across the desk from me, and he looked at me after some pleasantries, and he asked me the question that's remained on my mind now for 30 years. He said, "Why should there be an IHI?" Simple question that just is transformative. And you can ask that about your own organization. You can say, why should there be us? And until you have that answer clear, you really can't start. So I'm in deep debt to this man, and I hope we'll do him justice.
We miss him. Dawn and I have been sitting next to each other for about 25 years now. And one of the things that we've learned is that by sitting there and our different perspectives, that we will often ask each other questions that will help us to change our minds. This is, though, the first time that we've ever done a plenary together. And so bear with us. But what we did was we came up with, recently, thinking about aha moments, thinking about profound mind changes that we've had recently. And so we want to share this morning with you 5 different moments that caused us to change our minds. Dawn, the first topic is about measurement. And I know that you've come to think in a very different way about measurement and its role in improvement. What's changed?
A lot. We're going to cover 5 topics, but this may be in some ways the most important to me. It is often said that if you can't measure it, you can't manage it. I don't think I ever said that, but I sort of bought into it, but I abandoned that. I was always a little suspicious of that idea, but now, and I used to think it was innocuous, that was sort of a helpful notion. I think now it's absurd. I think it's destructive. I've come to believe that idea murders spirit, it dumbs down meaningful improvement, and I wish I could do anything I could to get rid of that notion. I should have had an inkling of this a couple of decades ago, actually, when there was a change in the sort of general theory in outside healthcare about improvement as the PDCA cycle, Plan, Do, Check, Act, which was originally known as the Deming cycle or the Shewhart cycle, got changed. And I don't know when it happened, but in the literature, it was transformed. I'd like to know the history of it to PDSA, from check to study. That's a highly meaningful difference. It's the difference between one enterprise, assessment, evaluation, judgment, checking on things, and a different enterprise, which is the enterprise of reflection and learning, which is the real foundation of real world improvement when you're doing it through change.
So I don't get why you think that's such a big deal. Like C to S.
It's a massive deal. Studying involves such a wider array of methods and approaches. It's actually a very familiar task for us in living most of our lives. For most of the things that we care about, we all the time manage without quantitative measurement. We still learn, but we're learning without numbers. Numbers can help, but so can stories, so can conversations, so can contemplation. When we use numbers sort of to help us, like we say, how far did the golf ball go, or how good was that movie on a scale of 1 to 10, or how cold is it going to be tomorrow, very cold or not. But we're the masters. We're not the servants of the numbers. And we're seeking answers that are just good enough for us to use at the moment. If I said tomorrow morning it's going to be 47.264 degrees Fahrenheit, that would be laughable. And the goal when you're learning, the goal of improvement, it's not generally accessible by any straight shot, any once and for all change. And so the way you improve is the way you drive a car. You continually adjust, you continually iterate, and single measurements of exacting accuracy, although they're useful when you're publishing a paper in the New England Journal of Medicine, they're not useful in improvement. Multiple measurements, just enough precision, that's all you need. In fact, over-reliance on measurement, it can be really a trickster. It can be very misleading.
So how does it lead us astray?
Measurement is always wrong. It's always wrong for several reasons. One is every measurement contains error. We know that. Measurement also casts a shadow over meaning. Measurement is always reductionist. It's always not really what we mean. Paul Batalden once said that measurements they're a shadow of a shadow, because we have something we care about, love or affection or resilience or health. And so we create a construct that is a faulty representative of what really matters. And then we add another layer, which is to measure that. So if you say how many dinners we share is a shadow of the construct of relationship, but relationship's actually an imperfect construct of the concept of love or connection. Measurement distances us from reality. It always produces misunderstanding, in my view now, unless measurement is tamed by conversation. I thought of, when I was preparing the remarks, to call its measurements a poor man's conversation.
So tell me an example.
There's really many. There are many examples. The one that I thought I'd share is back in the English NHS. As you know, at the turn of the century, the English NHS was plagued by long waiting times. Government took that on, and that, long story short, it birthed the 4-hour target for waits in A&E. The maximum acceptable delay before disposition of a patient after arrival to the A&E was 4 hours. One of the most vivid illustrations of the consequences of a reductionist view was actually published in all places in the London Review of Books a few years ago. It's a bar chart of the A&E waits in Staffordshire. And what you see is this immense spike at 3 hours and 59 minutes, and we saw it in the plenary yesterday morning. It's a game. Is this what you really want? Is this meaning? Does this have to do with what we're after in the underlying structure of addressing waiting times? What about a child with sickle cell anemia who's in crisis, whose pain is excruciating? 4-hour target? What about the man with crushing chest pain who better get into help? Or on the other side, what about a woman who won't need admission to the hospital if we wait just that 1 hour more to get her ready to go home? And think about the staff, the A&E staff, working as fast and as hard as they can to get the job done. What does that game do to them? What does it mean to them? What does it do to their sense of purpose, to the sense of agency that Derek and Jason talked about yesterday morning? What does it do to them, to the meaning in their work?
So you kind of changed your mind from measurement to psychology, or?
Yeah, there's a psychology to measurement. And actually, Brent James and I wrote a paper on this over 20 years ago. It was a paper published in the journal Medical Care. We had this diagram, which I know it's hard to read, but it's meant to show the double edge of metrics. Of course, we can use measurements sometimes, but the exact same measurement has a totally different valence, a totally different emotional feeling when it's used in the spirit of inspection or selection or choice or contingency. And on the other hand, how it feels if you're using it for learning and growth and development. Psychology matters profoundly. The other thing is that maybe tipped me even more is my growing awareness of the costs of measurement. Yeah. When you overlay on measurement, costs, they soar. The measurements themselves cost, and they grow in cycles, because if you produce a psychologically contentious measure, like the 4-hour target, what happens is the field then engages in countermeasures, like we saw in that diagram. And then you have to engage in countermeasures to get the metrics right. And you end up in the gaming cycle that absorbs billions of dollars, countless hours. And remember this may be a controversial statement, but from the viewpoint of the patient and family, all measurement that isn't embedded in, instrumental in care, all measurement that isn't instrumental is waste. All measurement is waste. The other final point I'll make is Bob Lloyd, perhaps our best faculty person in IHI in teaching understanding through understanding variation. He shows how misunderstanding is introduced by measurement that is unsophisticated. The red, green, yellow traffic lights, amber traffic lights, he hates them. I've come to hate them too.
I do too.
They managers and the public, they get these reports in great volume, but Bob shows clearly how the simple-mindedness of that misleads. It leads to conclusions that obscure the actual lessons.
So what should we do?
I think the key may be back to what I said about really understanding what it is to shift from PDCA to PDSA. It's the S, it's the study, it's the reflection that matters. We need to handle measurement with very great care. I think it's a beast. It's a beast, and it has to be tamed, controlled, limited. It has to be put to use for us, not the other way around. So never confuse a measurement with what is really important. The measurement is never what's important. Avoid sub-optimization by focusing on changing the result that is being measured. That will lead you astray. Use conversation first, last, and always. Embed metrics in conversation. If you're going to use measurement, master control charts. Learn statistical process control, the technical side of it. Get rid of those traffic lights and begin to understand what real variation is. Use graphs, not tables. That's a very simple lesson. And we need to put measuring on a diet, decide when enough is enough.
I went to visit a production plant recently, a very huge production plant, and I was struck that the leaders had 15 metrics, that was it. It was so much more lean than anything I've seen in healthcare. And those metrics then cascaded to the most incredible portfolio of improvement projects that I've seen. So it wasn't the volume of metrics, it was the scarcity of metrics that gave them the energy to improve across the system.
Yeah, I think that measurement on a diet is a good idea, and 15 is a lot better than 150.
Yeah.
So that's the first change in my mind about measuring. So let's go to one of yours. I know from watching you've been thinking very, very differently about mental health and mental health care. So can you tell us that story?
I have been thinking a lot. I can say that in my career, I've often thought that healthcare and mental health and physical care were kind of two separate areas, and I've come to believe that they're not. This is Mikey. Mikey is my nephew. Mikey, I took this picture at this joyous family reception that we were having, and I remember when I took the picture thinking how lucky we were to have such a healthy and loving family, and it was just the most wonderful day. What happened was Mikey became addicted to drugs. He grew up in the same city I did, and when I grew up in that city, it was a completely different place. For Mikey, every time he would come out of school, there'd be drug dealers standing outside his school, and he became addicted to drugs. When his parents found out about this, they got him into treatment. They were careful to watch his cell phone to make sure that there were no unnamed callers. It was quite a struggle, but Mikey came out of it and had 6 wonderful months of joyous times when I was taking this picture. Mikey had been drug-free for those 6 months when a drug dealer got him again, and the first time he took drugs again, he died. His grandmother found him. And that moment changed my life. I remember reading the obituary in the paper, and my sister and brother-in-law had written that he died after battling addiction. And I thought how courageous that was to put that in the newspaper and to tell everybody that this is the problem that Mikey had. And it really started me thinking how little I understood about how mental health and physical health need to be integrated in order to produce better results.
Sorry to hear the story, Maureen. What have you learned about the size of the problem?
Well, as I started to look into it, I found that the problem is much bigger than I ever could have imagined. Nearly 45 million people in the United States are affected by mental illness. 1 in 4 people is suffering every single day. More than 20 million people with a substance abuse problem, and more than 8 million experience both. And nearly 1 in 5 kids has had some kind of a depressive problem. It's worldwide too. 1.8 billion people have a mental health problem, and 80% of it is going untreated. When you look at our investment in mental health, it's less than 1% of global aid. So we've got this huge problem, and to my mind, it's been going untreated. Looking at drug overdose is a leading cause of death in the United States. Every 11 minutes, another life is lost.
Yes, 70,000 lives, I think it was last year, is that right?
And so what I did was I started to go out to the field and take a look at what it really looked like. I spent time in homeless shelters, and we'll hear more about that this afternoon. I've spent time in EDs where they were boarding patients because we had nowhere to put them. I spent time in physician offices watching a physician who was feeling, or a nurse practitioner, feeling so rushed that they focused in only on the physical problems and didn't really have the time to ask questions about the mental health and resilience and life circumstances that matter so much to people as much as the physical problems.
What's your understanding of the cause of this? Why is this happening?
Well, what I'm seeing is that their social isolation is producing a lot of this. Even with technology, what we're seeing is that kids who FaceTime all the time and never interact in person experience more depression and isolation. We're looking at the percent of high school students who say that they're depressed is increasing dramatically, and it's also happening with the elderly. As more and more elderly people are living alone, we're seeing social isolation have a huge burden on them as well.
So Tom would say, okay, let's fix it. How are you personally engaging with this now?
So what happened was, as I began to study this, looking around the country and around the world at the problem, I was invited by a group of nuns in the United States. There were a group of nuns who came together, and they wanted to solve a social problem. So they invited me to chair a board, and they invested $100 million and gave me 10 years to solve a social problem. And as I asked people around the country, what problem do we need to solve? It was unanimous: mental health. So we founded the WellBeing Trust. It's an independent organization that has in its mission an urgent need to work on mental health problems from early years all the way up to social isolation in the elderly, to look at teens and tweens, to look at opioid and other addictions, to look at depression. And across the United States, we're coming together to solve this incredible social problem.
So, what solutions are you discovering? What are the bright spots?
Well, I am going to share some bright spots with you, but I guess my favorite bright spot is being here today with 120 mental health practitioners and people receiving care who are here with the Mental Health Improvement Network. And I want to ask you to stand up. If you would, all the people who are working on mental health. Here's the bright spot. I was so excited to see you here. It's the largest number, I think, of people working in this part of the field that we have ever had at a forum, and I welcome you because we need your ideas. We need the 120 ideas, but we need ideas from everybody. So I want you to email me. I want us to begin to collect ideas from around the world. We do have bright spots, but we need to share them more quickly. One of them is George Halverson, the former CEO from Kaiser Permanente, has been doing research on the early years. He talks about the 3 key years and how important it is that we work on attachment and resilience in those 3 years in order to produce healthier lives. And Derek and Jason have been working in Scotland on, they started as the early years to try and create Scotland as the healthiest country in which to grow up. I visited the Royal Free in London, and the work that they're doing on patients, and you've probably heard of from Danielle Wild here, the patients with dementia. And East London Foundation Trust is doing amazing work, not only on caring for patients with mental illness, but also creating joy in the workforce. I visited the Recovery College in Northern Ireland, where people with lived experience are teaching courses to people who are suffering today. And I've looked at the Seattle in the United States with recovery high schools, where these students can make it all the way through high school feeling not only educated, but supported, and they come out in a better place. At the WellBeing Trust, we're working with musicians and radio broadcasters to create a program that is decreasing the stigma of mental illness for kids, for teens and tweens. And people who are their heroes are coming out and they're saying, be well, be heard, and be there. And we're giving these kids the tools in order to take care of themselves. I visited in Denmark with the leader of the Social Lance program, an EMT and a social worker who took the idea of an ambulance and said that's not good enough. Ambulances are focused physically and after a call comes in. The Social Lance is like a social ambulance that goes out to the field where people live and where they're struggling and is proactive and upstream about preventing downstream effects for social illness.
I'm hoping that in Copenhagen we can hear more about the Social Lance, so you're pretty excited about that.
I am very excited about it. I want you all to see it. It's going to make a huge difference. And the Moai social networks are forming. We took this idea from Japan and spreading it across the United States to bring elderly people together in a social setting. And it's decreasing their isolation, which is improving their care.
So what should we do?
So I have some guidance for you as well. I think we need to really think about prevention. I think we need to go way upstream and prevent mental illness. It'll be the best shot we've got at changing this problem. Focusing on early childhood, strengthening our connections to all the social networks, schools and community efforts, looking at timely access. The way people get boarded in EDs around the world still isn't acceptable, and we've got to increase the level of the number and the care level of providers, so we've got access when someone has a crisis. Work on social isolation and integrating all of these. And I want to end with those two words, and us, because as I'm seeing the burden of illness, it's affecting medical professions too. And too often I'll see a nurse or a clinician walking down the hall of a hospital, and they'll look at someone who's a care provider, a team member who's struggling with mental illness, and they walk by because they don't know how to deal with it. We've got to make sure that we're healthy as well. Vivek Murthy, the former Surgeon General of the United States, said, "Love is the oldest medicine." And I do think that we can love our teams and think about our patients in a different way, and that's going to really be helpful. So I'm wishing that I knew all of this when Mikey was sick, because I do think that all of us experience this in our families, and our ability to reach out and think about all of these causes will give us some of the ideas for solutions.
I just want to underline this shift, Maureen. You may not know, my own brother has struggled lifelong with substance abuse, and I think we all have our Mikeys.
Yeah.
And in terms of the list of what to do, I'll just say in my own reviews of this, but I know less than you do, this focus on early childhood that we see in Scotland, that is absolutely key. And if I could kind of declare one theme for the improvement movement around this arena, it would be work with children around adverse child experiences and figure out a way to crack that, because that is a tremendous generator of this.
Absolutely. So on to number 3, and here I've been watching Dawn's views change on the whole connection between technology and relationships, and I'm really interested to learn from you on this.
Yeah, well, the scales have kind of fallen from my eyes on this one. I'm perhaps immoderately excited. I used to think the digital revolution was marginal, like nice, cute stuff. I absolutely now have come to think, I could be wrong, that the digital transformation is going to be the most significant transformation in healthcare of my lifetime. We've seen unrequited promises a lot. I mean, nanotechnology and genomics certainly have not yet produced anything like what the hype said they might. And electronic health records, on the one hand, of course, we need them, but I think net so far it's negative. The electronic health record has distanced us from our patients. They've added layers of unnecessary waste to our processes. They've reinforced the status quo, and I'm hopeful, but so far disappointed. But on the other hand, massive changes in every other sector, energized by the digital revolution, and this is hitting healthcare and will in ways that I think are really, really positive. That's why, by the way, the IHI Leadership Alliance, which I get to coach in the U.S., has adopted as one of its 10 radical redesign principles is in pursuit of the triple aim, is move knowledge, not people. And I think that's not a bad summary of what I think this revolution may look like. Just to show you the revolution, you may have seen this thing from NBC a couple of years ago. At the top, you see the crowd in St. Peter's Square at the election of Pope Benedict. And 8 years later, that's St. Peter's Square at the election of Pope Francis. That's the new world, and it's the world of healthcare as well.
So how big do you think this can get?
Massive, massive. This is a complex area. Digital it's actually a potpourri. There's a lot of different topics within it, all of them exciting. One example is artificial intelligence and machine learning. This is using computers to do things the human mind can't do. You might have seen a number of years ago, the company, then little startup called DeepMind, was able to configure a computer to defeat the world champion player in the game Go. Go is one of the most complicated games ever invented. A Go board has more possible configurations than there are atoms in the universe. And yet these people were able to teach the machine to learn how to play Go better than the best mind in the world. That company, DeepMind, has been acquired by Google. It's one of the members of the family of things now called Google Health. that Google's preparing, even as we speak. And just in the interest of transparency, I am acting as a scientific advisor to Google Health right now, which is giving me some windows. A couple of things, for example, Google DeepMind Health has developed through machine learning, this is the computer learning without a human being instructing it, a way to predict acute kidney injuries in hospitals, in inpatients, days before any doctor or nurse has any suspicion that this patient was headed for AKI. And that program is fully in place and working steadily at Royal Free Hospital in London. This will be life-saving, cost-saving, and pain-saving. And much better, by the way, for the staff who are now getting assistance with artificial intelligence. Google DeepMind has also just published in Nature magazine. They're very committed to the scientific integrity of what they do. This result from machine learning methods to read optical computer tomograms. And that graph on the right here is comparing the level of performance of the machine reading the tomogram to the best human readers they could find, and the machine performs identically.
Don, you know me. I'm not so technical, and this seems a little esoteric. Yeah. So are there any simple things that I can understand?
Yeah, I'm not a digital native either, and this stuff blows me away. Nobody in this enterprise seems to be over the age of about 22. They're changing the world, but there are simpler things to do, really exciting stuff. I have to tip my hat to Kaiser Permanente here. I visited Northern California's region a few months ago. I saw their teledermatology now, in which basically more than half of the dermatology care is being given virtually immediately without any waiting at all and at far lower cost. In fact, more than half of all the care at Kaiser Permanente, at least in North Carolina, Northern California, is now virtual. I said controversially at the Leadership Alliance at a recent meeting that I'm beginning to wonder if, at least for some patients and some needs, the office visit is a dinosaur. Yeah. 2 weeks ago, I got to keynote the annual Meta Echo conference hosted by Dr. Sanjeev Arora and his colleagues at the University of New Mexico in the US. I met Dr. Arora, who's the guy with the tie on in this picture, more than a decade ago. And I've spoken about his work on Project Echo here at this forum in the past, but it continues to expand. Echo uses telehealth connections to allow experts in major medical centers to coach clinicians, doctors, nurses, community health workers in widely dispersed rural and low-income communities, first in the state of New Mexico, but now in nations all over the world. This allows clinicians to become what Aurora calls force multipliers. Their expertise exists, and the walls are torn away, the walls of geography and institutional barriers, so they can project help wherever it's needed, literally globally, even under the most austere circumstances. You can get the best expert at the University of New Mexico projecting knowledge into the most austere settings on Earth. Project Echo, in a few short years, has expanded into a global phenomenon. If you don't know it, you really should study it. The numbers are staggering. There are now 273 Echo hubs in 34 nations, and Aurora has announced their intention to reach 1 billion people by the year 2025. The sky's the limit, and when you sit in the Echo studio and you watch these interactions, you really see a completely new way of thinking about how expertise can reach the people who need it.
And so when I hear you talk about digital health, I think about digital health in two ways. The first way is how can we use machine learning and artificial intelligence to do what machines can do better than people. And I was recently at the Albert Einstein Hospital in Sao Paulo, Brazil, and some of the leaders are here, so you should try and seek them out. What I saw was amazing. The first was a command center where the machine learning is now getting better and better at predicting what's the probability of a patient needing an admission as soon as they come into the emergency department. A group of nurses got with some engineers and created this command center, which is improving flow. It's making the patient experience much better. It's getting the patient into the right bed at the right time. And as the machine learns, these kind of clinical indicators are likely to need these tests and this process to get them into the bed. What happened was, using the command center actually got flow to be so good that they didn't have to add 150 beds that they thought they were going to under the old way. And so I do think that it's producing joy in work. And this is their central command monitoring center, this looking at clinical care. Here they've got a group of non-clinician people who are noticing and notifying people when they predict that a patient is likely to undergo a complication. In doing this, they're taking the burden of running around like crazy people off of the staff and giving them the information that they need to make their care safer for patients. So what we're seeing is, I think, really dramatic improvements when we use AI and machine learning to do what it does best, and that frees us up to do the kind of care we do best. I kind of call it care at the web side. So I do feel very strongly about that. But that brings us to the fourth of our changing our minds, which is what the other part of digital health. And if we get the machines to do what they do best, then that allows us to do this kind of digital health. So this, with our hands, with our hearts, and that's the kind of change that I've gone through. Dawn has heard me talk about emotional quotient and empathy for years, but I came to believe that I've changed my mind about that. I've changed my mind from EQ, empathy quotient, to, I'm calling it CoQ, compassion quotient. And the reason is because you've probably seen me use this slide for years, saying I value IQ, I value empathy, and I value curiosity. But what I've come to learn is that empathy is your ability to understand what someone's going through. It's your ability to talk to someone and realize what they're suffering or where their joy is. But compassion is acting on it. Empathy plus action is compassion. And today, this is what I think we need. I'm building on the work that I would hope Jen Rogers can stand up and take a bow, and Andres Verge. Here we've... Jen here in Scotland and Anders in Norway took up a challenge at a meeting like this in Paris a few years ago when I said, you can't only ask a patient what's the matter, you have to ask what matters to you. And those two people, and Sean Ma and many other people in this room, have now created a global campaign. It's in 31 countries, it's spreading every year, where more and more people are acting with compassion because they're not only asking what's the matter, they're asking what matters to you. This is Jen on the left, sharing her work at the Pediatric Hospital in Glasgow. And on the right is the whiteboard that Anders revised. In the old days, it used to be a whiteboard in a nursing home that had the patient's name, their age, their DNR status, their doctor, and then everything else. And Anders transformed it, so now that it's the picture of the patient, what matters to them, and everything else. And I was standing with Anders in front of the board and said, what does this one say? He said, oh, that's an 88-year-old man who wants 2 scotches every night at 5 o'clock. And this one is an elderly woman who says, never take me out of my room without my hair done and my makeup on. But you stand in front of that whiteboard and you smile, you're filled with joy, and it gives you the ideas for compassion. Dawn and I've recently met with 2 physicians from New Jersey who've written a book called Compassionomics. We would highly recommend it because what this book is doing is it's telling us the linkage between actual clinical outcomes and compassion. And what they have found through their research is that patients who feel that their physician is compassionate in an ambulatory encounter actually end up with improved diabetic control. They use less pain medication. If an anesthesiologist comes out and meets the patient in person, puts their hand on the patient and said, I'm your doctor for the next 2 hours, I'm going to take care of you, this is the journey we're on together. The patients need less anesthesia and they require less pain medication. We're seeing clinical outcomes that I never would have predicted when compassion is a part of the equation.
I'll just put a word in about this book. Maureen and I don't know how these guys found us, but they just called us and we called them back. And this book, we have a pre-publication copy. I don't know if it's out published yet.
April 1st.
April 1st.
Tomorrow.
I'll just say, recommendation, one book to take away from this forum is this book. I don't think you'll discover it other than in our lecture, but you should read it, and it's stunning, and it'll change your mind.
So it's about acting on your empathy. You may have seen this hospital in the Netherlands that the doctors and nurses taking children to the operating room saw how stressed they were. They didn't just empathize, they took action, and they got all these little cars, and the kids now drive themselves to the operating room. It's a joy to see, and this is now spreading around the world in pediatric hospitals, that they're getting little Audis and BMWs, and they get in the car and drive themselves to the operating room. It makes all the difference, giving them control and not taking off their clothes, taking them away from their parents on a stretcher. You may have remembered this data that came out 15 years ago when they did a study and looked at the average time for a physician to interrupt a patient in an outpatient visit. Do you remember it was 17 seconds? What is it today, 15 years later? "11 seconds. So we're not getting better. We've got to change the way we work. One of my students at Harvard last year said, she's a physician at Mass General, and she said, "I feel empathic, but I don't feel compassionate." So she created a kindness bundle. She said, we have central line bundles and ventilated pneumonia bundles. We need kindness bundles. And these kindness bundles are now spreading across the Mass General system and much further. And physicians are finding, nurse practitioners are finding, that when they have a structure in their mind, the 11 seconds is erased, and they're starting to really listen to what matters to patients. It's changing the encounter. It's improving diabetic control. It's decreasing pain management. And one of our colleagues, Len Berry, is a professor at Texas A&M, but he's a senior fellow at IHI. And he's been doing research for the past 2 years, particularly on patients with cancer. But he's finding that basic acts of kindness lead to faster wound healing. Who would have ever thought? Reduced pain, anxiety, and blood pressure, and shorter hospital stays. So being kind can produce a faster pathway to the triple aim. And he gives us a whole way to think about what basic acts of kindness are, and then linking those to clinical and cost outcomes. It makes a huge difference when we start to think this way. At Mayo Clinic, you talked to Steve Swenson, who's here, about the research that shows that physicians who are burned out and stressed have 63% higher probability of being involved in a medical error. And at Beth Israel Hospital in Boston now, when a patient describes a circumstance when they felt lack of compassion, they now count that as a serious medical error. So we're on a path from moving from empathy only to really thinking about how do we act on that, and it's going to have a huge effect on clinical and emotional care. Don, what do you think about this?
Yeah, so when Maureen and I were putting together our list separately of things where we changed our mind about, this entered, we both put this topic, compassion, on our list independently and discovered we were on the same page. I thought compassion was an amenity, important, but secondary to the actual technical care. This is not true. Compassion is the source of healing, and I guess I sort of knew that, but I'm thoroughly convinced. Patch Adams has said, if you treat a disease, you win or you lose. If you treat a person, I guarantee you'll win, no matter what the outcome. Technology does heal. We're not dissing the technology, but we need to really get back to the concept that relationship heals in its own right. One of the things I presented at a keynote a couple of years ago that this brought back to mind is the work of Wayne Jonas, who's a colleague in the IHI intellectual community. Wayne wrote a really important paper summarizing the placebo effect. If you can find it, you should read it. Just to remind you of this result. So the typical randomized trial would compare an intervention to a placebo. In the case that I'm showing you here, this is a real surgery for angina. This is mediastinal artery grafts. versus sham surgery for angina, in which they open the patient up and they don't actually do anything. Famously in this study debunked the effectiveness of mammary artery grafting. There was no difference in outcome between the placebo surgery and the sham surgery and the actual surgery. And so that's the publication. But Wayne says, hold on a minute. 70 to 80% of the patients in both conditions had their pain relieved, dramatically relieved. And that is a standard finding of placebo-controlled trials. The placebo beats nothing. And Wayne's point is what's going on here? The placebo activity is in fact a form of care. What it is, it's relationship, it's compassion, it's commitment, it's interaction. And we've got to, if we could achieve the results with care the placebo achieves, we'd be getting Nobel Prizes.
So why don't we get this right more often?
I don't know. Sometimes this is something I worry about a lot, which is, can people really do this? Is this a question of human capacity? A friend of mine just last week told me a story from an airport. I can't remember the exact details, but he had come to the ticket counter. I think he was late for his flight, and technically the door was supposed to be closed, and he went to the agent, and she helped him. She said, yeah, okay, you can do it. But she said, this is the last time we're going to do this for you. Never ask again. I thought, was that stupid? I mean, here is a chance for this company to celebrate the generosity, and at the very last minute, by not connecting to the human interaction, that particular employee took away something very positive and made it very negative. Is this skill rare? Can it be taught or nurtured? The evidence is, as we heard in the plenaries yesterday, you can teach compassion, empathy can be taught, but we're really going to have to dig in and surface these capacities in the people who do the work. I personally, I just want to say, I think it has to do with what Jason and Derek were talking about. I think agency matters, this sense of I am important, and maybe moving to the upper right in Henry Tim's diagram about new power, but you were going to ask?
Give me an example of something you've seen where you see compassion make a difference in a community.
This brought me to tears. I live in the town of Newton, Massachusetts, and on Islington Road in Newton, a family adopted a child. I'm going to cry again. Adopted a deaf child, so the family had to learn sign language. And so 20 neighbors volunteered also to learn sign language. And now the whole community around that home are signers. If that's possible in human nature, then we have a chance of success. Let me say something else. I think something can be unleashed here, which is if we were to say compassion, the kindness bundle, matters, then we could unleash in the improvement community, I think, a raft of innovation ideas for fostering compassion as a mainstay in care.
Absolutely. We're going to have bundles everywhere, I hope. Make a bundle and send it on, because I think you're right. It's going to make a huge difference. So I've got some guidance. Dawn and I put together some thoughts for you to take home and think about. How do you incorporate asking what matters? Think about, can you use the Kind Care bundle, or can you make a bundle that will guide and help the teams that you're working with? There are so many ideas here. Doing PDSAs on compassion, just try it. I know that if you don't walk by a staff member who needs your help, it'll really make a difference in their life, but it makes just the same amount of difference in your life. And then take care of yourself, because as Dawn and I always say, you can't give what you don't have. So our last session is our last Changing Our Mind is about social determinants of health. And I know at the forum in December, you were very articulate about this. How did you get so passionate about this idea?
Well, stand back, I'm nuts on this one. Of course, I'm a pediatrician and father and grandfather, and I understand what social determinants mean. What I had no idea how powerful they are, and I spoke about that in Orlando in December. The social determinants of health and illness dwarf what we do in the US with our $3 trillion investment in health, and I had no idea. I think that maybe, possibly just as the digital transformation holds promise, maybe one of the biggest transformations facing healthcare in the next quarter century, I'd say, and this is in all countries, is to find a way to move our concern, our investments, our actions about social determinants of health from the annex, the building down the street, to center stage. That is not going to be easy. But I just don't see another way to deal with the generation of health. You saw the Glasgow effect discussed yesterday in the opening plenaries. This is a standard observation that inequities in health and life expectancy are enormous across very short spans. This is the map in London from Oxford Circus to East London, to Star Lane in East London. There is a 21-year drop in life expectancy. It's not a ramp, it's a cliff. It's not like it drops steadily. It doesn't. This is very place-based outcomes. But in this distance between Star Lane and Oxford Circus, you lose 8.4 months of lifespan for every minute on the tube. You lose 2.6 years of lifespan for every mile on the tube. To tell you how big that is, as you saw in Orlando, if you were there, take a medical miracle, statins, if you believe in them. I have my doubts, but there is some evidence that statins do prolong life and reduce coronary disease. If you take the most favorable statin result, which was published in the BMJ in 2015, the basics are for every year on statin, on average, you gain 1 day of life. For 20 years on statin, you gain 20 days of life. So that's the statin effect. 20 days of life is equivalent to riding the D train in Manhattan from Midtown Manhattan to the Bronx. For the first 7 seconds of that trip, you lose 20 days of life. In the Glasgow bus or tram, you lose 20 days of life in the 43 feet of travel, at least according to the 2004 data in Glasgow. I have to tip my hat here to Sir Michael Marmot, who's the source of much of this knowledge. I tried to sell his book. I don't get a commission, but in Orlando, I sell it here. If you haven't read The Health Gap, you must read The Health Gap. It will tell you more than you have ever known about the power of these determinants. Marmot sums it all up in inequality. His finding is inequities in power, money, and resources give rise to inequities in the conditions of daily life, which in turn lead to inequities in health. And let me editorialize to say that as the First Minister spoke about yesterday and the Cabinet Secretary today, this is all about solidarity. This is all about being together. And tearing ourselves apart from each other is a formula for perpetuation of the inequities that are at the root of social determinants of health. This has been more recently, this is Marmot's categorization of what you must work on. This is the to-do list. If you want to close this gap, work on early childhood, like Maureen said on the earlier slide. Work on equity in education, which the Nordic countries have done. And by the way, the Nordic countries have erased relationships between educational status and longevity. Work on the conditions of work, exactly what Jason and Derek are talking about. Agency saves lives. Work on the conditions of aging, because when elders are involved actively in society and are not lonely, and Maureen emphasized social isolation, their lives get longer, not just better. Work on community resilience, especially agency, the ability of communities to do what Henry Timms was talking about in the New Power arrangement, and on fairness. And by the way, you saw all of this in the purple. What was it?
Purple Poncho.
Purple Poncho group. The sense of agency and power there, I am absolutely sure is prolonging the lives of those dedicated and charismatic people. Since I'm in Scotland, I'll tip my hat to Sir Harry Burns, who's, like Michael Marmot, has been one of the great minds, one of the great leaders, a surgeon who migrated to this area because he changed his mind. And he's one of the great advocates and explainers of the power of social determinants. And the Nobel Prize-winning economist, Angus Deaton, whose work I hope you will become familiar with. Deaton has written deeply in the past few years of what he calls deaths of despair. If you look at the cliff between West and East Chicago or across Star Lane in England, what you'll find are deaths of despair, suicide, substance abuse, and alcoholism. That explains a lot of this. And so if we don't work on equity and we don't work on the conditions of life, we can't produce health.
Do you see any progress?
Yes, it's in pockets now. The investments are wrong. We're putting so much into allopathic, traditional care that we don't have the money left over to work on this. And I think the reallocations need to happen. We're seeing it. I'm seeing it in England, for example. England is now investing in integrated health systems, one of the most exciting evolutions I've seen. I hope in Copenhagen we'll be able to review some of the progress. I visited Gloucestershire a couple months ago and saw the Treasure Seekers program. This is for the 700 most seriously mentally ill people in Gloucestershire. The Acute Care Trust, the hospital and the mental hospital, they are helping develop resource bases in the communities. Treasure Seekers has developed the Cavern, which is it's a basement in a building on High Street in Gloucester, where these 700 people are welcome to drop in anytime, 365 days a year. They're open every single evening. At the Cavern, there is music. They could play their music. There's a coffee bar. They could be baristas. They learn to be that. They get a trade. There's a living room, which is, by the way, populated with mental health professionals who are there to help the people who show up. Because of the functioning of the Cavern, mental hospitalizations in Gloucestershire have plummeted. And the police there was a policewoman in the Cavern when I was there, and she said people who were in her police station 5 times a day are now never seen there because they have a home. I'm seeing this in policy emerge, at least on paper, in the English National Health Service. There in January 7th, 2019, the NHS published its long-term plan. It's an absolutely thrilling document, if a 134-page document can be thrilling. It's long, but it is terrific. And there's a tremendous amount in this plan that contemplates finally putting the resources where the health can be found. And I'm pretty excited about what would be possible there. I will also say, by the way, the NHS long-term plan has a big play in digital health, just like we were talking about before, that transformative view of what's possible with thorough use of the modern digital architecture. So yes, there's promise. It's going to be political. We are going to have to reallocate resources to the social sector and integrate leadership of social care and health care. And then back to our theme, this is the relationship to improvement. Are there tests of change here? Can we use PDSA cycles as the way to take improvement theory back into working on real social determinants? I sure hope so. And I think it's going to be possible.
And I agree. My mind has been changed on this, just like Dawn's. I came to one of our friends, a physician in the United States named Rishi Manchanda. He invented a new medical profession that I really love. He calls it upstreamism. And it's really thinking in a totally different way. And our colleague Tom Nolan that we talked about earlier, he says we need a master plan for the community. And I really love this idea. If we were, as an example, to take a look at San Diego, we could see here that 3 behaviors are causing 4 diseases, which produce 50% of the premature deaths. That's a master plan. When you look at it that simply, it gives you a way to think about what's the most important place for me to put our energy and what should we do. Or we could do something like visit the medical school in Cuba is producing physicians now that understand all of this. Their first year, they're out in the community, they're working with people, and they understand all the social determinants, and that's what they begin to work on. And you can see in their school children that in 2 generations, they've gone from being one of the least healthy populations with high rates of obesity, smoking, hypertension, and chronic disease to being one of the most healthy. And they've done it by teaching health in the 1st grade. We visited the 1st grade class, and I was overwhelmed with looking at how beautiful the curriculum was because they were teaching them how to be healthy. So, as we wrap up, we want to help you to keep an open mind. Dawn and I push each other all the time to change our mind. And we have some ideas for you on how you might keep an open mind when you go back. First, ask what matters to you. Build on your curiosity. I would say learn to see go visit a healthcare organization or a supermarket or any kind of a place you happen to be in, and ask yourself, what was this like 5 years ago or 10 years ago? How have they shifted the balance of power to the customer? And how might we use those lessons to co-produce healthcare and new designs? Harvest ideas everywhere you go and bring those back, because that's what we do. We're constantly saying, I visited someplace and this is what I saw. And then going back and forth, it actually does, though, after you see something, require you to go back and think, how does that fit in with my mental model, and am I ready to change my mind? I think that's going to be the critical way to think. One hint is go to the Gemba. Walk the work, sit with a patient, look at the patient's journey over the course of a year. Watch a visit in a hospital or in an outpatient encounter, or follow a nurse, even for an hour. You'll get your steps in for the day, I guarantee you. Ask a child, what do you think about health and how do you think about care? Or ask Doug Eby, who's here today from the Alaska Native Medical Group, to teach you how to introduce yourself as a Native American. What I'm finding is that if you walk up and you introduce yourself as a Native American would, what I would say is, I'm Maureen Bisognano. I'm married to Chuck Newman. We have 3 kids. We just got a new dog, the first dog of my life. We play golf every Saturday morning at 6:09. And then you say your professional stuff. What about you, Don?
Well, I'm Don Berwick, and my wife is Ann, and I have 4 children and for their spouses, and the 7 best grandchildren in the world. And I'm about to go to Morocco on vacation.
And so what you find is when you introduce yourself that way, the conversations change. People will come up to you and say, I just got a dog, what kind do you have? Or what's your handicap in your golf game? And it makes relationships happen that opens up your mind to really thinking about where you're stuck and what kind of ideas you might want to bring back to work. And that's what we need. We need to change our minds.
And I think it starts with some humility. The thing that amazed me about Tom was his constant willingness to rethink. And I'll speak to the leaders in the room, you know, and Derek has mentioned this quite a bit in his teaching. You've got to believe that you could be wrong. And the humility to actually wonder all the time whether there's something you don't know, somewhere you need to go, and something you've got wrong. It's absolutely key to improvement, and that's the meta message that Maureen and I were hoping we would convey. For every change we're talking about, where there is activity now, and IHI is wonderful projects on metrics and making them more meaningful. Pedro Delgado's leading an effort to think about how to become how to reach, increase our reach by 100-fold, and that's only going to be accomplished through the digital age. We are working much more on mental health, on social equity and disparities, and moving more and more, I think, into understanding the emotional side of care. Open-mindedness is everything. Someone once warned me. He said, Don, if you're too open-minded, your brains fall out. I have now come to believe that's a risk I am more than willing to take. I prefer Einstein's advice. Einstein said we cannot solve our problems with the same thinking we used to create them. So changing your mind, it's an essential skill, and we wish you well.
So how did we do?